My first guest today is someone who I've known for maybe a year or two, who has really been one of the preeminent researchers in Europe in MRI, Dr. Boesen. Mikhail, why don't you tell the audience who you are and what your research interests are? I think they'd find that very interesting.
Yeah, thank you for the opportunity. My name is, as said, Michael Boesen, and I am a radiologist and heading the research, MRI research in musculoskeletal imaging at the Frederiksberg Hospital in Copenhagen. And what our primary interest is actually is imaging within the rheumatological field, and especially my own personal interest is imaging, trying to quantify inflammation, because I've worked with ultrasound and ultrasound Doppler, which is a beautiful tool in the hands of the skilled, but has a lot of potential pitfalls in order of quantification of inflammation if you use the Doppler. And that's where I saw that MRI definitely could give us much more insight and also a higher reproducibility of what we are seeing in inflammatory joint diseases. What frustrated me with the conventional way of saying the static MRI was actually the fact that the synovitis tend to, let's say, be a rigid score in terms of when you saw a clinical response and you couldn't actually see it in the images, whereas bone marrow edema was more like a fluctuating process.
So as we've heard at this meeting, and I think, to be fair, you are so far ahead of a lot of the average people out there, but it would appear that right now bone marrow edema or osteitis has been recognized as probably the most legitimate biomarker for rheumatoid arthritis, a precursor for progression of disease and a measurement of disease response. But your point is that it's really telling half the story. It's really not telling us about synovitis as well. And we know that when we saw at our meeting at ISOMIA, there are certain values that ultrasound brings to the table, certain values that MRI brings to the table. And what I think you were referring to, and I'd like to clarify, is that in fact there is a way in which you can actually bring both values to the table at one time.
Yeah, thank you. Thank you, Norman. I'm glad you asked, because that leads me to the point where we actually could bridge the two imaging modalities, and in one stop shop, if you can say it, get the benefits from both modalities by doing what we call dynamic contrast enhanced MRI. It's a fairly simple procedure where while you give the contrast during the MRI, you do a lot of fast imaging sequences to see where the contrast goes, how fast it comes into the joint anatomy, and by that being able to quantify the flow or the inflammation in a better way than the static images have told us previously. And by saying that, we also know that osteitis and bone marrow edema, being a true inflammatory process within the bone, it actually carries new vessels and also enhancement. So osteitis will enhance, and by using this technology we can both see the enhancing synovium as well as the enhancing bone. So it gives us a more functional view of the patient's inflammation, and I think that's a potential tool of the future.
And I think that to explain it to our audience, in fact, the actual MRI technology that is being utilized to measure these patients is really exactly what we're doing right now. It's the software that is an add-on, and it's simply giving the contrast to the patient the same way as we would be doing it right now. Yeah. So really, from the physician side, from the radiologist side, there really isn't anything different that has to be done. It's simply, on the other side, using your dynamic software, you're able to analyze the flow of the vessels in synovium and bone marrow to an extent where we can really see change in disease in a very rapid time. Is that correct?
Yeah, that's definitely correct. But what you have to be aware of, as you said, gadolinium contrast is needed. So you have to, let's say, go the step and give it. And if you give it, then you get the benefit and actually can combine the static MRI with the ultrasound Doppler information.
I mean, you know, one of the things in the United States in particular is there's concern, well, gadolinium is potentially toxic to the kidneys. But in reality, as long as you look at a patient with normal renal function, do you feel there's any downside to using contrast?
No, not at all. And you can look at the FDA recommendations here, and they say that as long as you give what we'll call a normal dose of gadolinium contrast, giving after the kilogram of the weight of the patient, then there's no report at all that is toxic. So to be on the safe side, you could check the patient's renal function. As long as they have a normal renal functions, there's no problem at all. But even though you don't know the renal function and the patient is under the years of 60, then you can give it without taking a kidney sample or a blood test for the kidney.
Renal function.
Yeah.
So, as this train goes by, I'll just give us pause. But what I want to do is, I actually want to focus on the topic of your presentation that you made yesterday, which I thought was totally fascinating, in which you really showed how by using dynamic contrast and using computer software, you're able to almost come up with a measurement that is an automated measuring device that is equal or maybe even better than the standard OMERACT joint count, which we know is very laborious and time consuming and potentially filled with errors. So maybe you'd want to give us a little background on that.
Yeah, what we've used the last couple of years exploring this technique was, first of all, to develop the software in collaboration with Olga Kubasova at Image Analysis, but secondly was to see how that software could help us put dynamic MRI analysis into the concept of the current ways of doing it. And using the Ramriss OMERACT criteria as the standard of reference, then we have put this software and compared it to that, and we can see a very high comparison up to a 0.9 for the Ramriss scoring of synovitis and bone marrow edema. But it gives you even more. It gives you both the volume of enhancing tissue in the bone and in the synovium, but also it gives you how fast does this contrast comes into the joint, meaning that how high is the inflammation. You see the hot spots in the joint, and if you want to target your therapy with a intra-articular injection, well, my experience is that you get a much better patient response if you do it in the hot spot of the inflammatory process.
So are you telling me that you're actually using the hotspot that you're seeing as a target guide for your needle?
Yeah, I don't do it because I'm a radiologist, but I show the image. I'm suggesting it to the rheumatologist that we have at our hospital. I hope that more people would actually take it up, and by saying that, it's actually possible to do this technique with the current ways of doing it on both low field scanners like the 0.2 Teslas that we have a lot of places in the world where the patient is not competing with others to get the imaging, but also on the very high field strengths like the 3 Tesla I presented yesterday. So we have a paper coming out on low field data in 3 weeks in rheumatology showing the high correlation with the dynamic MRI analysis as well as and the Ramriss scoring.
So let me ask you, with this automated calculation, do you think that radiologists should fear that they're going to lose their jobs?
No, actually not, because they can speed up the process of analysis. And what we were doing, we were timing our process of doing a Ramriss score and doing this approach, and you can save half the time by doing it. So what you don't get by doing dynamic analysis is you don't get the erosion score, but the erosions is let's say the endpoint of the disease, and we should prevent the erosion from happening. So what we want to target is actually the inflammatory process leading to the erosions.
I think that's very well said. I mean, to me it seems that if you look at bone density, how being able to automate a number made such a difference in terms of new treatment therapies being introduced into the marketplace, and in particular, if I'm hearing you correctly, clinical research studies for new drugs in rheumatoid arthritis should be shortened dramatically by using this technology to really speed up the evaluation of whether these drugs are working or not.
Yeah, surely there's a potential for this to be used as that, because what we see is that if you give a steroid injection in the knee joint, for instance, you shut down the dynamic inflammation signal in 2 days. and the patient is symptomless after 2 days, whereas the static imaging changes are visible after at least a week more. So it is a potent technique that could help us, let's say, do phase 1 and 2 trials on new drugs, but also what need to be further tested is how should we put it into a clinical setting, and how long should the follow-up period be. We don't have these data yet, but hopefully, let's say, more would join in and use this imaging technology to solve these questions.
Fascinating, exciting. Thank you so much, Dr. Michael Boesen, and good luck for what you're doing, because I think it's just amazing. And for me as a practicing rheumatologist, to see the evolution of the technology and how it's changing the way we treat patients is absolutely amazing. So good luck and thanks again.
Thank you very much.